Hello, my name is Brittany Spees, and I'm doing the acute kidney injury case study on Miss Barkley. She's a 64-year-old female. So the first thing that I'm going to do is go ahead and walk into the room and do my QSIN. I'm going to look at what position she's in, whether her bed is all the way to the floor or not, whether it's locked or not, how many side rails she has up, if she has any tubes, lines, any drains, any oxygen, any IVs, if she has any clutter or anything like that to any of our exits, and then making sure that her whiteboard is updated with the correct providers and her healthcare team, and then making sure that she has her bedside table and call light within reach. So I'm going to go ahead and walk in and introduce myself. Hi, my name's Courtney. I'll be your nurse today. We're going to go ahead and ask her name and date of birth, and then match that to her ID band, and then match that to her chart before I do an assessment. So her vitals are, she had 100 and her temp was 98.6. 103 was her heart rate, respiration for 16, blood pressure 118/68. Her pulse ox is 96, and she has a pain rated 6 out of 10 on a 0 to 10 pain scale. Right now I'm just looking at her chart. She has orders for continuous tele, INO measurements. We need to keep her pulse ox above 92. She's NPO, strict NPO. She has a order for Dilaudid, 1 milligram IV push every 3 hours, as needed, moderate to severe pain. And then she has a order for Zofran, 4 milligrams PRN nausea, but it doesn't give me a route and it doesn't give me a frequency. So we're going to go ahead and call the doctor to clarify that order. So first thing I'm going to do is ask her name and date of birth. She can answer that. I'm going to ask her if she knows where she is, what date it is, why she's here. Alright, she can answer all those correctly, so I'm going to start off with her Perla, 3 millimeters. I'm going to have her sharpen right to the side. No JVD noted. I'm going to go ahead and look at her skin. It's intact, it's pink, it's warm, it's dry. I'm going to have her wiggle her fingers for me, and then I'm going to have her turn her arms around so I can check her radial pulse. So it is, she has a bounding pulse, and it's a little rapid and irregular. So I'd sit there for the full 60 seconds and count her pulse. So I'm going to go ahead and have her give me grip. Okay, so grip is moderate bilaterally, and have her push me and pull me. I'm looking for any edema or anything. Now I'm going to go ahead and do her respiratory. I'm going to ask her if she's been experiencing a cough lately. Every time I touch you with my stethoscope, take a deep breath. I'm going to listen to her apical heart rate, so I can hear S1 and S2. Alright, I'm going to go ahead and sit up for me. I'm going to turn around and measure her ventilatory depth. So, her respirations were regular and unlabored, but crackles were noted bilaterally, anterior and posteriorly, and then she had no cough. So we're going to go ahead and move on to her abdominal assessment. So the first thing we're going to do is inspect the abdomen. I'm going to go ahead and ask her if it's tender or not. She said yes. So the first thing I'm going to do is auscultate. When was your last bowel movement? Okay, so they were active ×4, and then going to palpate very carefully. She said it was tender. So it was tender. She's complaining of nausea and vomiting. She said that she's not having any painful urination or discharge. But she voided 200 milliliters of dark concentrated urine, so I went ahead and charted that. The next thing I'm going to do is come down here, have her wiggle her toes for me. Oh, sorry. Push, pull. Checking for any edema. No edema noted. I'm going to check her pedal pulses. I'm going to go ahead and check cap refill on each toe. And then I'm going to ask if she has any pain, paresthesia, numbness, tickling, or like paralysis, and she says no. So going back to that order. So I have an order for 500 milliliters of 0.9 normal saline. So 500 milliliters over the course of 1 hour. And then I also have an order for Dilaudid, 1 milligram given via IV push for moderate pain. And since she rated her pain at a 6 out of a 0 to 10 scale, I'd say that's moderate. So, which I mean, I would check the orders to see the specific parameters said, but. So the first thing I'm going to do is go ahead and give her some patient teaching. So she's getting the fluids because she's having some severe dehydration. She's been 12 hours NPO without any IV fluids. And she had the IV contrast, so that's probably not helping either. So we're going to go ahead and explain to her. So I said, she's getting the fluids because she's severely dehydrated. And then we're going to give her the morphine because she's having some pain, obviously. I'm going to go ahead and assess her heart rate, her blood pressure, and respirations before I give the morphine. And it says to dilute it with at least 5 milliliters of sterile water or 0.9 sodium chloride for injection. Inspect solution for particulate matter. Slight yellow color does not alter potency. Store at room temperature. And I'm going to administer this slowly at a rate not to exceed 2 milligrams over 3 to 5 minutes. And then rapid administration may lead to increased respiratory depression, hypotension, and circulatory collapse. So I need to be giving this over 3 to 5 minutes because we're only giving her 1 milligram. So I'm going to go ahead and also I'm going to take her vital signs one more time before we give her this. I'm going to go ahead and reassess her respiratory status and her cardiac status and look at her blood pressure. I'm going to go ahead and assess her IV site as well and flush it to check patency. So first thing I'm going to do is go ahead and check the orders. I'm going to go ahead and clarify. So I have some new IV tubing here. So I don't actually have a bag of normal saline. Sorry about that. So I'm just going to pretend that I do. So I have the bag of normal saline. I have the patient, so I'm going to go ahead and scan the patient and check and verify name and date of birth, and then scan the bag, making sure that I do my rights. So right patient, right time, right drug, right dose, right route, right reason, right response. And then I'm going to go ahead and, like I said, check that to her chart, compare it to her chart. I'm going to go ahead and put a label on it so we know what it is, and then write the date and then the time I gave it, or time I hung it, I mean. So I'll go ahead and spike the bag, so spiking the bag, and then I squeeze this chamber and then open the clamp and let it prime itself all the way to the end of the tubing, making sure there is as little air bubbles in the line as possible. And then I'd hang that bag. Before that's, I'd assess her allergies since I'm giving both medications at once. So I've already assessed her allergies and double checked everything like that. Like I said, I already checked her IV site and flushed it for patency, making sure we were looking for swelling, any redness, pain, anything like that. Don't want that to infiltrate. So the next thing I'm going to do is prepare her Dilaudid. So I'm wanting to give 1 milligram. So I have my vial, my alcohol prep pad. And obviously I would connect the tubing to her J-loop or her saline lock. And when I do that, I would alcohol prep pad both ends and then connect it and tape it so it doesn't come off. So I'm going to go ahead and alcohol prep pad the vial. I washed my hands and put gloves on, obviously, before I did this. I'm going to go ahead and draw up how much I'm wanting. So we'll just say 1 milliliter is 1 milligram. Making sure that my dosage is right and everything, too, while I'm doing this. So I go ahead and inject the air, and then pull up however much I wanted and safely do that. And then going to tap any air bubbles. Recap that needle. I'm going to go ahead and, like I said, recheck the orders and then scan her and then scan the med to make sure everything's okay. And I'm just for the heck of it, I'm going to reassess her allergies too. Like I said before, I've given her this Dilaudid. I've already, she's rated her pain 6 out of 10. I've already looked at her vital signs, reassessed her lung sounds, everything like that before I give this because this can lead to respiratory depression. So we don't want that to happen. So I'm going to go ahead and get a alcohol prep pad. And then we use needleless systems. So I would go ahead, I'm just going to recap this needle. And then I'm going to screw off the actual needle part. So just to get the thing. And then I'm going to go ahead and close the clamp. That way I know exactly how much is going in and what I'm using to flush with and all that fun stuff. So I also have a flush with me. I'm just gonna pretend like this has water in it. So the first thing I do is go ahead and I have gloves on, obviously. I've already provided patient teaching for this also, so I've given her why we're using it, some side effects, and then the expected outcome that we're wanting. And then I'm going to use the port closest to the patient. Okay, so I'm going to go ahead and connect this and then flush it, about half of it. Okay, so flushing. So next thing we're going to do is have our med here. My alcohol prep pad the end of that, and then alcohol prep pad the end of the port. Connect our drug here. And like I said, I'm going to administer this 3 to 5 minutes. So yeah, I'm going to go ahead and so I administered that over 3 to 5 minutes, and I'm going to go ahead and just clean the hub one more time because we don't want no hospital-acquired infections up in here. No, no. And then I'd obviously use a cap of some sort to make sure that that stays clean. And then, did I already do this? I'm not sure. I'm going to do it again. I'm flushing it a second time. Make sure I get all that med. I want it out of the tube and into the patient. So re-cleaning this, recapping it. Sorry, I'm not sure if I already did that or not, but we'll just say that I didn't. Alright, so afterwards, so I'd come back and reassess her vital. I'm going to come back, reassess her vital signs. And everything about 30 minutes later. And then I'm going to come back also because we have that 500 milliliter bag hung. I'm going to come back at 10 o'clock because it's only over 1 hour. So I would come back because the infusion is going to be complete at that time, and then reassess her once again for any fluid volume overload or anything like that. And I came back at 9:30 and reassessed her vital signs and INO. I flushed her IV, and then I went ahead and reassessed her pain at 10 when her normal saline was finished. And she rated her pain a 4 on a scale of 0 to 10. So that means that the therapy was, it was a therapeutic dose. So yeah, I'll just be reassessing her heart rate, her blood pressure, and her respiratory rate and status and everything like that. And yeah, so I think that's about it with that. I want to make sure we get the right response. Okay, so I guess I'm ready for a report off now. I don't know if I said this, but I would do her name and date of birth separately for both meds, because I'd have to scan patient med, whatever. Anyways, so Mrs. Barkley came in. She's 64 years old. She's a female. She came from a nursing home. She had acute abdominal pain, nausea, and vomiting for 2 days. She had a CT scan with IV contrast. Showed no acute bleeding, possible small bowel obstruction, but they never clarified that. She's admitted for bowel rest, and she has some orders for continuous telemetry, strict INO, making sure that we're keeping her pulse ox above 92, and then she's strict NPO. She has an order for Dilaudid 1 milligram IV push every 3 hours, PRM for moderate to severe pain. I went ahead and gave that at 9 in the morning. I charted that, and I went ahead and reassessed her pain, and it went from a 6 to a 4, so that's pretty cool. Then I gave a order for some Zofran, 4 milligrams PRN for nausea, but I had to call back to the healthcare provider and have him clarify that. So her vital signs were 98.6, 103 was her heart rate, respirations were 16, her blood pressure was 118/68, her SpO2 was 96, and like I said, she has a pain scale now of 4 out of 10. I went ahead and did another pain assessment, abdominal assessment, cardiac assessment, respiratory assessment. We're watching her fluid, her overall volume status, and then making sure we're watching her skin too. So just keep rechecking those. She had 200 milliliters of dark concentrated urine out, and I charted that. Make sure that we are recording the INO and then notifying the doctor if she has any low output, and then yeah. So we're wanting a BMP or renal function panel and a chemistry because she's having low urine output. So I went ahead and bolused her with 500 milliliters of normal saline. It just went over an hour. He has not put any new orders for that. So they did about a bladder scan, and it showed 60 milliliters of urine in the bladder. She had some crackles in her lungs, and her SpO2 dropped to 89%. So we went ahead and put her on 2 liters of oxygen to keep her stats above 92. And then I also notified the healthcare provider of her BUN, creatinine, and GFR and her potassium levels. I'm anticipating, the doctor never hasn't called back yet, but anticipating him to reorder some more fluids for her dehydration and then some diuretics so she doesn't have fluid overload. We're thinking she has an acute kidney injury. I am so sorry. Or some acute kidney failure. The severe dehydration, IV contrast, and 12 plus hours of being NPO without fluids caused the kidneys to have a low flow, and the contrast may have caused some damage to the kidneys, which that did not help. So yeah, basically just, making sure that we're keeping up on her pain, making sure that we're communicating with the healthcare provider on her fluid status and her renal function and hepatic function, anything like that. So that is about it. Yes, thank you for watching.